Imagine going into surgery to fix a structural issue, only to wake up with a complication that makes physical intimacy permanently painful.
Yeah, that is a terrifying thought.
Right. But that was the reality for nearly 1 in 5 women undergoing traditional pelvic repair. We are talking about a scenario where fixing a structural hernia, ironically, swings the surgical pendulum so far in the opposite direction that it creates a completely different functional nightmare.
Exactly. And the clinical texts refer to that functional nightmare as introital stenosis. Basically, the vaginal opening, the introitus, becomes severely strictured and narrowed.
Which leads directly to dyspareunia, right?
Yes, that's the medical term for chronic painful intercourse. And today in our deep dive, we are extracting the exact architectural blueprint from modern surgical guidelines to answer a highly specific question for you.
Right, which is what surgical modifications to a standard posterior repair or perineoplasty are actually required to prevent that stenosis from happening in the first place.
So to really grasp those modifications, we need to quickly look at the anatomy being repaired. Usually a patient is coming in for a posterior colporrhaphy, a posterior repair, because they have a rectocell.
And just so we're all on the same page, a rectocell is when that strong fascial layer of connective tissue between the vagina and the rectum weakens.
Right, it weakens and the rectum starts bulging forward into the vaginal canal.
Which causes this awful dragging sensation,
Yeah.
sometimes making normal bowel movements incredibly difficult because, the anatomy is literally out of place.
And frequently, that repair is paired with a perineoplasty.
Right.
The perineum is that crucial span of skin and muscle between the vagina and the anus. It's really the foundation of the pelvic floor.
Because childbirth can tear or overstretch it, right? So surgeons perform a perineoplasty to reconstruct those muscles and rebuild the pelvic base.
Exactly. But the problem was how surgeons historically went about fixing that base.
Yeah, this is where it gets rough. Before we get into how modern medicine avoids creating a stricture, we have to look at the traditional methods that actually caused it.
Right. Because historically, when a surgeon looked at a rectocella, they didn't see a specific tear in the tissue. They just saw this generalized baggy weakness.
And their solution was, well, it was surprisingly blunt.
Very. They relied on a technique called levator plication. So the levator antemuscles form this broad, dynamic sling supporting the entire pelvic floor. They act much like a flexible trampoline.
A trampoline that's meant to move and stretch.
Right, but in a traditional repair, the surgeon would make a deep incision and aggressively cut away wide strips of the vaginal lining, the mucosa.
Because they just viewed it as quote-unquote excess stretched skin.
Exactly. Then they would reach deep into the pelvis, grab the levator antemuscles on the left and the right, and stitch them tightly together in the midline, directly over the rectum.
I was reading the clinical descriptions of that midline plication, and honestly, the mechanics of it are startling. You're taking a muscle group meant to act like a flexible hammock and binding it together to create a rigid physical wall.
It completely alters the mechanics.
It's like trying to tailor a loose, baggy shirt by just grabbing a massive fistful of fabric right in the middle of the back and aggressively sewing it together.
That is a great analogy.
Right. You make the shirt tighter, sure, but now the fabric is bunched up, it's pulling at the shoulders, and you can't actually move your arms. The dynamic function is totally destroyed.
And the human body reacts very poorly to that loss of dynamic function. By pulling those muscles out of their natural lateral positions and stitching them into a thick ridge in the midline, surgeons were essentially creating an artificial speed bump in the vaginal canal.
Ouch.
Yeah. And when you combine that rigid muscle wall with the aggressive removal of the vaginal skin, the fallout is severe.
The data from a study we reviewed by Melgren et al. Really puts a number on that fallout. They evaluated traditional posterior colporrhaphies and found that up to 17% of patients complained of intense introital tightness post-surgery.
17%.
17%. It triggered a high rate of de novo dyspareunia.
So women who never had pain during sex before the surgery were suddenly experiencing agonizing pain every time, purely because of the way the repair was structured.
But here's the thing. For decades, the medical community accepted that 17% as an unfortunate but, necessary side effect.
Which begs the question, if surgeons knew this was causing painful complications for nearly 1 in 5 women, why was it standard practice for so long?
Because the primary, almost singular goal of gynecology in that era was anatomical success. The organ was prolapsing, the surgeon stopped the prolapse. By their metrics, the surgery worked.
So the rectocell was cured, but the patient's quality of life was severely diminished. Exactly. And the evolution in modern urogynecology has been the realization that preserving the structure means absolutely nothing if you destroy the function, which forced a complete pivot in how the surgery is approached.
And that pivot is where the specific modifications come into play. Once it became undeniable that aggressively excising tissue and binding those levator muscles caused introital stenosis, the clinical guidelines had to change.
Right, they had to adapt. And the most critical shift is moving away from that generalized tightening toward what is known as a site-specific repair.
The source texts compare this modern approach to forensic architecture, which makes perfect sense when you look at the anatomy.
Yeah, because a rectocele isn't just universally stretched out tissue. The research, which was heavily driven by figures like Richardson back in the 90s, proved that the bulging is usually caused by discrete, specific tears in the rectovaginal fascia.
That's the dense connective tissue layer separating the vagina and the rectum, right?
Right, so instead of blindly grabbing muscle and pulling it to the center, the modern surgeon acts like an investigator. They meticulously dissect the tissue layers to find the exact edges of those fascial tears.
And once they find them,
Once identified, they stitch only those specific breaks back together. They repair the defect by reattaching the fascia to its original anatomical anchors, like the uterosacral ligaments higher up in the pelvis.
so they're repairing the actual defect rather than just masking it by building a giant muscle wall. In fact, the Atlas of Pelvic Surgery has a massive, bold warning about this.
Oh yeah, it's very explicit.
The primary rule to prevent stenosis is do not placate the levator ani in the midline. Doing so guarantees that rigid, painful ridge we talked about.
The data is definitive on that point. Making the shift to site-specific fascial repaired the paramount modification. But the second major modification deals directly with the surgical scalpel itself.
Right. This is governed by a mantra that appears repeatedly across the clinical texts. Quote, "You can always cut out more, but you cannot put it back once it is gone." End quote.
Which is such an important rule in surgery. To avoid narrowing the canal, surgeons have to adopt extreme conservatism when excising the vaginal epithelium.
Because in the old days, they would carve out large strips of that skin.
Right. But today, the guidelines mandate removing only a carefully measured, tiny diamond-shaped piece of tissue from the perineum and the very lowest part of the posterior wall.
And the biological mechanism driving this conservatism is super crucial. The vaginal mucosa isn't just an inert lining, It carries a rich microvascular network.
Exactly. When a surgeon cuts away large swaths of that skin, they are simultaneously removing the underlying blood supply. The body responds to that surgical trauma by laying down dense scar tissue, which is a process called fibrosis.
And fibrosis is the absolute enemy of elasticity.
The absolute enemy.
When that tissue scars over, it loses its ability to stretch, leading to chronic vaginal dryness and a rigid, unyielding canal. The surgeon is literally shrinking the internal diameter of the vagina, and no amount of physical therapy or stretching is going to bring that amputated, scarred tissue back to normal.
Right. Which means if the surgeon is being hyper-conservative with the internal tissue to avoid shrinking the canal, they still have to rebuild the structural support for the prolapse.
So the focus has to shift somewhere else.
It does. It shifts outward. And this brings us to the third modification during a perineoplasty, targeting the superficial muscles.
So rather than digging deep into the vaginal wall, the surgeon looks at the external support structures, specifically the superficial transverse perineal muscle, often abbreviated as the STP.
The STP and the bulbocavernosus muscles. These muscles sit right at the base of the pelvis, wrapping around the vaginal opening.
Okay, so in a modern perineoplasty, what do they do with them?
The surgeon identifies these superficial muscles and sutures them together in the midline.
Ah, I see. Think of it like building a retaining wall on the outside of a tunnel. By bringing those superficial muscles together, you're restoring the structural integrity, adding vital bulk to the perineal body and providing a strong external corset.
Exactly. You support the pelvic organs from the outside without medically causing a shrinkage of the internal space.
You give the pelvic floor back its foundation while leaving the internal volume completely intact.
It is a really delicate balance of engineering, and it requires constant vigilance while the patient is still on the operating table.
And that real-time assessment during the operation is our next critical area of focus. Because, even with a perfect site-specific fascial repair plan, the surgeon is still manipulating living, bleeding tissue.
Yeah, things change in real time.
Right. They need a reliable way to ensure they haven't accidentally over-tightened the repair before they close the incisions.
Historically, the standard intraoperative check was the two-finger rule.
Right, the two-finger rule.
At the completion of the posterior repair, the surgical guidelines stated the surgeon must verify that the vaginal lumen easily accepts 2 fingers.
Okay, but I was reading through the contemporary clinical pushback on this, and it makes complete logical sense. Wait, the texts point out that relying on tactile feel is inherently flawed. 2 fingers on a surgeon who is 5'2" and has small hands might be vastly different from the 2 fingers of a surgeon who is 6'5".
It's wildly different.
Isn't there a better architectural guideline? Subjective feel is simply not an objective means of assessing optimum diameter. It leaves far too much room for error.
You're totally right. And the modern literature strongly advocates for architectural geometric guidelines over subjective tactile measurements. The surgeon must meticulously evaluate the angles and contours of the repair.
So what's the first check?
The first geometric check is ensuring there is absolutely no posterior vaginal wall ridge. If the surgeon runs a hand along the repaired back wall, it should be a perfectly smooth curve.
And if there is a ridge?
The presence of a sharp ridge indicates that tissue has been dragged too tightly to the midline. That ridge will act as a physical barrier, triggering intense pain upon any penetration.
So no ridge. What else?
Beyond ensuring a smooth wall, the surgeon must evaluate the terminal angle of the repair. The posterior vaginal wall and the perineum must intersect at a strictly perpendicular relationship.
A 90-degree angle.
Yes.
Because if that angle becomes acute-like, if the tissue is sloping inward too sharply, the opening is geometrically too tight, signaling an impending stenosis.
Exactly. And finally, the surgeon evaluates the overall vaginal axis. The very top of the canal, the vaginal vault, should maintain a slightly posterior direction. It needs to point directly toward the hollow of the sacrum at the base of the spine.
So by verifying these 3 precise geometric relationships, the smooth wall, the 90-degree perineal angle, and the sacral axis, the surgeon confirms they have restored the natural 3-dimensional capacity of the pelvis.
They're actively preserving the spatial relationships rather than just, sewing a hole shut.
Which is incredible. But the sources we reviewed also detail the corrective modifications. We've established how to prevent it, but what happens when a patient walks into a clinic with post-operative introital stenosis from a previous surgery?
Yeah, that's a tough situation.
Let's say they had that traditional levator bretation 15 years ago. They suffered through the aggressive tissue excision, and now they're dealing with severe fibrous strictures. How does a modern surgeon reverse that damage?
Well, reversing a stenosis is a notoriously delicate challenge. The surgeon is no longer dealing with a simple structural hernia. They're confronting an absolute lack of native tissue, compounded by dense, unyielding scarring.
Right.
So the foundational corrective modification for this is the Fenton's procedure, or the modified Fenton's procedure.
And the geometry of the Fenton's procedure is brilliant. To release the tension that's narrowing the introitus, the surgeon makes a longitudinal incision, a straight vertical cut over the lower vagina and the perineum. They cut directly through that restrictive band of scar tissue.
But if the surgeon were to simply sew that vertical cut back together vertically, the tissue would scar in the exact same orientation and the stricture would return immediately.
Right, you haven't actually changed anything.
Exactly. The ingenuity of the Fenton's modification happens during the closure.
After making that vertical cut, the surgeon pulls the sides of the incision apart so it forms a diamond shape. Then, they take the very top point of that diamond and stitch it down to the very bottom point.
Right.
In doing so, they sew the wound closed in the transverse or horizontal direction. They literally take length from the vertical axis and force it to become width on the horizontal axis.
It permanently widens the opening by surgically altering the orientation of the tissue. It is an incredibly effective technique, provided the patient still has enough pliable local tissue to work with.
But in severe cases of isolated introital stenosis, that local elasticity is completely gone, isn't it?
Yeah, unfortunately.
There isn't enough stretchy tissue left to perform a Fenton's procedure. That's when the clinical texts introduce techniques borrowed directly from plastic surgery, like the double Z-plasty and the VY advancement flap.
Let's break down the mechanics of those flaps, because they are vital tools for a reconstructive surgeon. A double Z-plasty is utilized when there are tight, web-like bands of scar tissue. The surgeon makes a central incision along the scar and then cuts 2 triangular flaps on either side, resembling the letter Z.
Hence the name.
Right. By physically swapping the position of those triangular flaps, They elongate the contracted tissue, instantly relieving the tension and breaking up the linear scar.
And for even more severe tissue deficits, they utilize the VY advancement flap. I was looking at the diagrams for this, which are often used in radical vulvectomies or severe
That's
restrictions.
a major intervention.
The surgeon makes a V-shaped incision on the skin outside the vagina, typically utilizing healthy skin from the gluteal area or the inner thigh.
The critical step there is mobilizing that V-shaped island of skin while keeping its underlying vascular supply entirely intact. Once mobilized, the surgeon advances that flap medially, pulling it inward toward the vaginal inner wall, and stitches it into the narrowed space in a tension-free manner.
And when they close the surrounding donor area, the incision forms a Y shape.
Exactly. A V becomes a Y.
And the result is a brand new patch of healthy, vascularized, flexible skin pushed right into the strictured vaginal opening to widen it out. But, I mean, we have to acknowledge the absolute glaring irony of these corrective procedures.
Oh, the irony is immense.
We spent the first half of this deep dive detailing how traditional surgeons aggressively hacked away vaginal mucosa, genuinely believing they were doing a good job by tightening things up. To fix the damage caused by that overly tight posterior repair, the modern reconstructive surgeon has to harvest skin from the thigh or the buttocks, mobilize it, and advance it inward.
Yep.
They are performing complex geometric operations, desperately trying to put back the very tissue the first surgeon threw away in the garbage.
It underscores exactly why those modern preventative modifications are so paramount. Conservatism, site-specific repair, and preserving the local architecture aren't just suggestions. They are the shield against catastrophic functional loss.
It is a profound lesson in surgical restraint. We have covered a tremendous amount of ground today. Let's pull it all together and recap the core findings for anyone navigating these clinical concepts.
Sounds good.
To prevent postoperative introital stenosis during a posterior repair or perineoplasty, surgeons must actively avoid traditional levator anapplication, which creates a rigid, painful ridge. Instead, they need to utilize a site-specific fascial repair, acting as forensic architects to find and fix the exact tears in the rectovaginal fascia.
And they must adhere to strict conservatism with mucosal excision, cutting away as little vaginal skin as possible to prevent fibrosis.
During the operation, they must replace the subjective two-finger rule with architectural geometry, ensuring a perpendicular relationship between the posterior wall and the perineum, a smooth posterior wall, and a vaginal axis pointing toward the sacrum.
And if a stricture has already occurred, reconstructive options like the Fenton's procedure, Z-plasties, and VY advancement flaps manipulate the tissue geometry to restore the lost width.
Understanding the specific mechanics behind a levator plication versus a site-specific repair isn't just academic trivia. I mean, it is the exact knowledge a patient needs in the consultation room. It gives you the clinical vocabulary to ask your surgeon precisely how they intend to handle the fascia and how conservative they plan to be with the mucosa.
It empowers the patient to advocate for their functional future, not just their anatomical present.
Absolutely. But before we wrap up, I want to leave you with one final, slightly provocative thought found in the source text that really flips our understanding of pelvic anatomy upside down.
I know exactly what you're going to bring up.
Yeah, it's fascinating. We have talked a lot about fixing things that are too tight, but the texts have a whole discussion about patients who seek out a perineoplasty specifically because they are experiencing this sensation of a quote-unquote wide vagina, often after childbirth, and they feel a loss of sexual function.
Right. And the instinctive traditional approach for a surgeon looking to tighten the space might be to perform a vaginoplasty, to go deep inside the vaginal canal and aggressively excise mucosa to make the internal tube smaller.
The logic being, if it feels wide inside, make the inside smaller. But the clinical data reveals a paradox. To successfully treat the feeling of a wide vagina without causing the chronic pain of stenosis, the surgeon shouldn't actually remove much internal vaginal tissue at all.
It's counterintuitive, but true.
Instead, by purely repairing the external perineal muscles, bringing together that superficial transverse perineal muscle on the outside and slightly lengthening the perineum, the entire dynamic structure of the vaginal wall changes. It creates a new backstop, a new foundation of support during coitus, and the sensation of internal looseness completely resolves.
It brilliantly challenges our basic assumptions about the human body. We assume that to fix an internal symptom, we must alter the internal environment.
But sometimes, changing the foundation on the absolute outside is the only way to fix the feeling on the inside. It is all connected. It's like a suspension bridge, you know? You don't tighten a sagging bridge by pulling the cables closer together in the middle of the span.
Right, you secure the anchors on the shoreline.
Exactly. The architecture of the pelvic floor requires exactly that level of respect. Well, thank you so much for joining us on this deep dive. We hope you walk away feeling empowered and armed with the exact right questions to ask. Until next time.